respiratory to separate the periosteum. Maybe for the flat bones, the
Bone cutter.
yes, Dahlgren bone cutter. Then the Lewis bone cutter. Is it here? Liston. This one is Liston bone cutter.
Liston.
Yes. Liston. This one is the osteotome, grooved osteotome, and this one is also osteotome. Hammer. And here, what else? Да, я убрал. Wait, please, for your work, wait, please, because firstly on consultation. And the one more question for the instruments is, you must choose the special instruments needed to perform the amputation. Half of them, which I named now, is for amputation. Yes? This one is for amputation, retractor. Amputational knife, where is it? Two. To cut the soft tissues. Laminar saw, maybe use the jiggly saw. Of course, the respiratory. I think so. It is for instruments for the instruments. Next, some of the questions for the puncture of the joints. For the joints, first of all, you must know the points of the puncture. If it is the shoulder joint, it may be 3 variants of the puncture. Yes, anterior. According to the coracoid process, you must palpate firstly coracoid process. From the lateral side, acromion, and from the posterior, also acromion. The one is from the lateral side of acromion. One is the posterior to it. There are 3 puncture for the shoulder. For the elbow, 2. Lateral and posterior, both according to the olecranon. One is the back, one is the side of it. For the wrist is only 1. 3, 2, 1. 3 maximum, middle, and 1. 1 for the wrist, it is the, you must join 2 stellate processes and the second,
metacarpal.
yes, the joining of these 2 lines at this point for the puncture. When you will explain it, please take the needle for the puncture. That you know that the puncture, for the puncture, you need the needle. Because the only one instrument for the puncture is needle, maybe the syringe, but syringe is absent here. For the hip joint, how many? 2. First is anterior approach, second is the lateral approach. The posterior, the muscular layer is very big. That is why it's impossible from the posterior side. For the knee joint, around the patella, parapatella approaches. And for the ankle joint, 2. For the lateral side and for the middle side, 2. You must know it for the punctures. Then, for the paranephral novocaine blockade by Wisniewski, also firstly you must know the point where it is located.
2 and 3.
And yes, it's the cross section of these 2. But, my friends, please palpate yourself where it is. Because on the skeleton, no one can show it. Palpate yourself the rectus spinae and the 12th rib, and you will know where this point is. And one more thing about the paranephral blockade by Wisniewski. How the surgeon know that the procedure is done correct?
By the moving of the needle up and down. No, sir.
But first of all,
Disturbance of pain?
yes, of course, because the main indication is the colic, renal colic, hepatic colic maybe, but firstly is the renal colic. Colic, what is it colic? It is very sharp, very strong, very hard pain because of the what? Extra contraction of the smooth muscles. And to relax these muscles, first of all, you must, and as a result, if you will do and the pain will not reduce, you must think what happened, what else? The moving after then only. But if the pain will reduce, no problem with it. First of all, the reducing of the pain, of course. For the lumbar puncture, how we know where the level of the puncture?
Minus process of third and fourth.
No. Are you X-ray eyes? Huh? How you know? Yes, both iliac. You must join, and this line, it is the level. You must palpate the spinous process, or above it, or below it. Without X-ray, you can palpate and join this line too. It is the level to palpation. Shkolnikov-Selivanov is the puncture of the technique nerve blockade. Firstly, the point, where this point is situated. 1 cm medially to the anterior superior iliac spine. 1 cm medially. And the technique, where the all plexuses of the pelvic plexuses, where they are situated. They are situated near to the sacrum. Near to the sacrum. But how it is possible from the point, the puncture, to sacrum? How? You must step by step, you must firstly do parallel to the skin, to puncture till the bone. Then 1 millimeter back and change the angle. Again, 1 millimeter back and change the angle. And the one by one, step by step, the end of the needle will go near the sacrum. And if it is one side, 400 milliliters of the 0.25%, you can, yes, you can inject. Because the maximum dose for the middle person, it is 1 gram of the novocaine. If it is 0.25, maximum maybe 400. If it is 0.5, 200. But for one side. If it will be two sides, you must divide for same parts. The technique of the suture by Carrel. It is suture of the vessel. What is the main stages of this procedure, of this operation? How the Carrel, why? This surgeon. Do you know that the 1913, the Carrel, the Nobel Prize gives from the Nobel Committee for the Carrel by this suture, for the vessel suture, because it's very easy. To do it is very easy. To stitch the vessel, it is necessary. Firstly, join the round vessel, joined by the 3 threads. 3 threads which give us the chance, if you will straight it on the opposite sides, the vessel will change triangular. And the straight part is very easy to stitch than the curve. That is why this, the main purpose stitches by the Carrel. And other variants are very difficult, but the Carrel is easy because firstly apply the 3 threads, after the assistant turn the sides, and the surgeon stitch one side, after then change it here, after then opposite here. And in the end, these long threads must be cut, and the current suture finished. For the all about approaches, my friend, technique of approach for axillary artery. I said for you in the classes that this firstly projectional line. For example, if it is brachial artery, how the surgeon will do it? By the line, projection line, where the brachial artery is situated inside. It means where the projection line of the brachial artery. It is medial brachial groove. In this groove, the surgeon palpates the artery, and after then along the artery, cut the all layers till the artery. It is straight approach. As example, straight approach. But maybe 2 cm up or down, it is collateral approach. It is not straight approach. If it is some problem on the way, the surgeon can use yes, one of the variant of approach. For this, all arteries and the rest are by the what? First of all, you must study the repeated projection lines of each of these arteries, or maybe the nerve. For the Pirogov fat space, technique of draining of Pirogov fat space, where this fat space is situated, the inferior third of the forearm. It is fat space between third and fourth muscular layer. The inflammation from the thumb or from the little finger, because the sheath of the tendon is very long, that goes for the fat space. That is why, if it will be the inflammation of both or maybe one, the spread here, yes, the pus will accumulate here. And to operate, to cut it, both sides, laterally and medially, the surgeon cuts just the soft tissues, after then take the forceps, and after then without cutting, without sharp instruments, just open between the between the muscles and between the fascia. And after then it is necessary to drain by the some tube, small tube, to drain this fatty space. By the practical skill. Any questions for me? Not only by the practical. The tendon sutures, you must just write the scheme of it. By Lange and Cuneo.
It's same for both of them.
No, it's not same. Why is this same? No, it's absolutely different.
How many questions will come in the final paper?
So, for Lange, you can see it is like U shape, but also for the both sides. And the node will be outside the tendon, here, on external surface. While by Cuneo is like 8 in shape, a lot of crossing, and after stitching, after making the node, they will be between distal and proximal. No, between two parts of the tendon. The node will be inside the tendon, while by Lange, it is outside. This one is the worse than this one, because you can't do the early moving of the tendon because of the regeneration of it. And if the patient will do the early moving, this node will difficult than when the node is inside, and a lot of sutures inside, and they are fixed hard than by Lange.
So how many questions in the audit paper?
For the objectives, first part objectives, only 10. One answer, 1 point, maximum 10. For the objective, 2 questions. Practical, sorry, 2 questions. 15 maximum by 1. 30 both for practical. And for oral, 4 questions by 10 maximum, 10 points for the one each question. Yes.
Sir, out of 4 questions, 2 from topography.
Yes,
and
yes.
2
As usually, 2 from topo and 2 is from the operation, as usually. And it is like for the different parts. If it is, for example, topography of the kidney, the second will be operation on the pelvis. Third, topography of the upper limb. Fourth, operation on the lower limb. They are different parts as usually.